to have to do the best that we can, and I need for you to at least understand basic principles. So I will be reviewing what those basic principles are, okay? And that is to make sure that you can recognize the components. So you will see those pictures again. You need to make sure that you're using the appropriate terminology so that we're always on the same page. And as we go through our simulation clinic exercise, we will have some challenges because we are essentially just rigging it to work so that you get a good idea, I wouldn't say this is going to be good, but get an idea as to what would it take for you to restore a single tooth implant, okay? So it will be slightly frustrating because it's not going to be maintained within your patient, but we're going to try our best to see how it works. And so if you could just be patient. And again, if something unusual happens, you lose something, you drop, break, dent something, you need to let me know sooner rather than later so that we can make adjustments so that you're not behind, okay? In essence, we're already kind of behind in the course. So today what I want to do is spend just a little bit of time and give you a little bit of information about the surgical guide. So we've already discussed the edentulous area, correct? We've discussed treatment planning for that edentulous area, and we've discussed components. Now we're going to talk about how do we, I think that's me, that's one of you guys, so make sure you're careful with your mic, okay? We want to discuss how do we communicate with our surgeon, whoever that may be, an oral surgeon, a general practitioner, or a periodontist, placing the implant. The surgical guide, is the most important communication tool between the surgeon and the restoring dentist. If that's the same person, well, guess what? Now you've dotted all your I's and crossed your T's. Make sense? This is going to provide 3 particular types of information. The exact location of the implant. The restoring dentist determines where that needs to be based on where the restoration is designed to be. The angulation of that implant fixture and the depth of that implant fixture. Now, as it relates to angulation and depth, there are a whole lot of other caveats related to the surgical technique that I'm not going to get into. We are going to focus on at least you understanding that the guide is going to provide the exact restorative position or location for your restoration. If the surgeon is not able to place the implant where you've designed it to be, then that implant should not be placed. Now, that is what I like to believe. In reality, that doesn't always happen, okay? So I won't go further with that. We just know that the surgical guide has 3 tenets. For the depth of the placement, for an aesthetic area, the depth of the implant placement is critical. For aesthetics, if you want to make sure you're not going to see that fixture or grain through the tissue when the patient smiles, so that means you need to make sure that you evaluate how high of a lip line or smile line that is. And ideally, this is an ideal placement. Your hands to yourself, please. Can you turn the thing off or is it always on? Your implant should be placed at least 2 to 3 millimeters from the final restorative margins, okay, or finish line, all right? And that's also going to give you some leeway to develop your soft tissue contours. In this diagram, it is showing you an anterior tooth. And we would like to be able to think that as long as we have alveolar bone that we can have that lovely papilla. It doesn't always happen that way often. But if we, in a perfect world, this is what we'd want it to look like. Yes, sir?
Without the periodontal apparatus, is it not going to eventually shrink back anyway?
If you do not have bony structure, the tissue will not remain. It's a miracle at best. Now there's some ingenious things that we can do to help try and create or maintain some of it, but it depends on the staging of your surgery and how you're doing things. But 9 times out of 10, if this was due to trauma and you have no bone, then that bone can't support the soft tissue and it's not going to magically just be hanging out there in the wind. Okay? So that's something you have to think about. And so if you don't have soft tissue there, then you've got to be looking at or thinking about a very wide restoration, right? And then you're having a conversation with your patient about, yes, I've replaced and restored the space, but is it the most aesthetic result? Perhaps not. You want to start having a conversation with that patient at that point. This is the best that we can do right now. If that's not acceptable, then you have other surgical means to try and achieve that. There's grafting, which takes time, right? So it just depends on how much time and money your patient is willing to or desires to go through for an ideal result. I use the analogy all the time. In a perfect world, I'd like to just be 5'5", but even with 3-inch heels, I'm nowhere near that. So I have to accept where I am. Okay? And I'm okay with that. Managing the edentulous areas. If the space will be restored with an implant in the edentulous area, we need to do a diagnostic wax up, which you have already started. Everyone has finished that, yes, by now? Okay, I see stares. I'm going to pretend I didn't see. Or you could utilize something as simple as a denture tube, okay, just to make it easier. In this case, I did not want you to break up your denture tube setup so that Dr. Love would not be mad with me. If the space is to be treated with an implant has a tooth in good anatomical form, let's say if it even had a some chipped anatomy and not having enough proximal contact, you could be ingenious and simply add to that. You modify it so that your wax up is not all the way from scratch, which is what I asked you to do, but you can modify it. You could even use a preformed crown and modify that. Cut, take away, add, whatever you need to do to try and achieve some type of aesthetic result there. Okay, something basic to start with. And that'll be more apparent once you begin to make a provisional restoration for your patient. But it is important for you to think about what is going to be your goal, what can you achieve, and accomplish for this restoration. Okay? So here in the top right-hand, left-hand corner for you is your patient. And we've utilized 3 denture teeth to create the anatomical form that we desire. Okay? It doesn't necessarily have to be all fancy with the pink wax, but at least if you need to take the time to make sure you're developing the appropriate contours now, so that the surgeon puts the implant where you desire it to be. If you slack on this, then the surgeon is starting off without enough information and will just put the implant wherever he or she decides to place it. That then makes it more challenging for you to restore. Not only challenging, it can become very expensive. You want to make sure that you're able to use stock components versus a custom abutment or custom components. Once the word custom is introduced, that is going to be a cost to you and your patient that you have to discuss early on. And so then that cuts into your overhead and your profit, right? So at all costs, you're not planning to use custom if you don't have to, but it happens. So the first thing you're going to do is just simply create a cast. Right? You're going to place that tooth back in, you're going to take an alginate impression, and then create a solid cast. You're then going to remove, and we've already done this. So if your wax up is not maintained on your patient, you can simply duplicate that cast and take the wax up off. Does that make sense? So then we don't have to go through all of this of cutting, removing where the X is. Okay? The X is the tooth, and in our case, we're only doing 2. And I believe we're doing it number, refresh my memory, 9, or is it 8? 9 and 13? Like there. You have no idea. Okay.
One of the codes is 29.
Nope, this would be the maxillary arch. That's
4, 5, and 9.
Yeah, that's fine. So your goal will be you're going to remove where the red one is, and you're going to draw a blue line around the cervical or gingival margin area, facial and lingually, and you're going to highlight the height of contour all along the facial and lingual surfaces of your cast. Yes?
Technique is probably lining up through the ground lab.
No.
So if you look at this, how do you remove that?
If you use a knife, you're probably going to nick the adjacent teeth and knock off the rest of your teeth. So I would probably use one of your lab cutter straight hand piece burrs.
So the
For the plaster burr that's non-clogging, but be very careful that you don't take off a nail or cut your hand, all right? Or again, since for your cast that we created the wax ups for, I asked you to wax directly to the cast. What you can do is take the wax up off, duplicate that cast, and now you have a cast. You don't have to worry about removing a nail from the nail bed, okay? Just depends on how hard or how smart you want to work.
How do you duplicate a cast?
So even though you waxed proximal contacts, you should still be able to take that wax up off.
An
It
impression
should just
of
pop right off.
cancer.
There's no such thing. You're just going to take an alginate of your cast and you just report. Because this is your other diagnostic cast you need to maintain. Okay? So this will be another working cast. You're going to, and you notice that you need a cast that you're going to create that cylindrical hole in the center that you will also utilize your lab cutter for. Okay?
When we first put it up, we were missing 17. We changed the teeth last week.
So this would just be for the maxillary arch. I asked you to have, and the central, no, just the maxillary arch. So this should be a central incisor and a premolar. So that would be either 8 or 9, or 12 or 13, I believe. Or it could have been 5.
Very confused.
Okay? And for our purposes, because we only have one set of analogs, let's just do the central to make it easy for everyone, okay? And then we won't have to worry about the closing occlusion, okay? So it needs to look like this. And it's both on lingual, you're doing your diagrams on the facial and the lingual. And you should make sure that you show faculty this as you're doing this. It's best to do this when the cast is dry. So that also will give, you need to have some time to make sure it's dry, all right? We will provide you with vacuum material of the appropriate thickness. And I need to verify and pull out, make sure we have enough of these. I think we only had 2 in the other building, and I hope that we should be able to get 3. The challenge will be with 70 plus of you all, by the time we run 20 of these, the handles on the machine will be hot. I've had 2 students to receive second-degree burns on their hands because of that. So this will not be something that we can all do in one setting. It's going to take some time, okay? I don't believe there is one in the dental clinic either. So I would say if you wanted to go over to the dental clinic, that is not even an option, okay? So we will at least try and make sure that we have 3 machines out, and if not, it's going to take us some time to be able to do this, okay? Because I don't want anyone to burn themselves. And we'll have faculty there assisting so that we don't have the
Why don't
secondary
we just
burn.
get oven mitts?
Oh, it is important, notice that once we distribute the material to you, it does have plastic coating on both sides. Please that is to make sure that dust does not get on the material and you set a fire once you're going to heat the material up. But you also want to make sure you remove the blue protective plate before you insert it into the machine, okay? It will melt, it will catch fire, so please don't do that. Or be careful not to do it. We will go through and show you how to utilize this. In essence, the hole in the center is going to help you to remove that with a little bit more ease, okay? And that's important. Either you could create the hole or you could put like a quarter or a nickel underneath the cast on the mount of the vacuum form, okay? So essentially, you can see here, we're going to you allow the material to heat and slump to about this degree, so it's about 8 to 10 millimeters there, and then you're going to engage, bring the material down and engage the suction so that it adapts. And the blue lines are there to help you with how far you're going to then relieve and cut. So ultimately, you want a very nice integration all the way down. Don't be so concerned if you end up with seams, particularly at the corners of the arch, like in the canine region. And that's just a factor of how long you let the material heat and slump and how well of a vacuum that was formed. Okay? So if it does happen on a critical area, we're just going to keep going. Okay? So the crease won't be such an issue. So you'll end up with something that's to the right there. And you're then going to have to go through and remove all of this very carefully. I would say your first, rather than going to the next step, your first order of business would be to cut any excess material away from the cast. That's going to be the safest way to do this first. And you should have a pair of blunt nose scissors to be able to do that. Okay? Then you're going to utilize a Robin bristle brush to remove, again, you would remove all of this excess with the scissors, because people have cut themselves trying to do this. And then you're going to use the bristle brushes right at the necks of the teeth of your cast. So where that blue line is drawn. It's best for you to start longer so that you can trim your way up to where it needs to be, instead of trying to trim right to that blue line right away, because you'll end up trimming too much and it'll be too short. Does that make sense? So leave room for you to be able to trim back to where you want to go. And it's probably going to take several of these, several bristle brushes trying to cut this off. Okay, so don't freak out with that. So we're going through all of the fun time of reducing and cutting. It should come off and on the cast relatively easy. In the instance that you break off any incisal edge or a cusp or a tooth, you're just going to have to keep going. You do not need to re-pour a cast and all that. This is a working cast and it's probably going to happen. All right? And this is showing how you can use scissors just to trim a little bit of excess. I would start with that beforehand. And ultimately, this is what you want to end up with the image on the right. So a little bit longer than where that blue line is. Okay? Next, you're going to essentially remove the tooth with the X. Probably not with a burr that looks like that, because you would slice your finger, but get rid of it with your lab cutter burr. And you're going to make the area nice and concave so that you have something that looks like this. And let's just focus on the area for the central incisor. All right, so you're now nice and trimmed to that tighter contour, both lingually and facially, and you remove the tooth on your cast. Please note that the area for the missing tooth is concave to simulate extraction or removal of the tooth. That's important. You're going to then block out in approximately, not so much so on at the height of proximal contact, but at the gingival area, because as you trim, that's where you could potentially have material to lock in. And this should be easy. You could, either use Play-Doh or rope wax. It shouldn't be a surgical procedure. It shouldn't take you that long to do this. You're then going to create your own X in the edentulous area and simulate where you want the surgeon to place your implant. And X marks the spot. We're just going to go right down the center. We're not trying to angle anything. We're not trying to be creative and have an angulated abutment, a custom abutment. Put it in the center of that space, period. You're going to take a round burr and mark the spot. And it's just about half the diameter of that, your surgical number 6 round burr that you should have. I think you have a 6 or an 8 round burr in your lab cutter kit, right? Maybe? We'll find out. If not, we'll have some. Okay? You're then going to place 2 holes into your guide. This is going to allow for injection of orthoacrylic material. You're going to then, I would probably start with your Vaseline on a dry cast. Then you're going to put several coats of all coat, letting them dry in between. So at least, more is better, maybe 4 or 5 coats and let it dry in between. And again, that's in hopes that the material won't stick, but if it does stick and you break off a tooth, adjacent tooth, try not to freak out. Just show us and we'll reassure you, and you're going to keep moving, okay? But usually if you put the Vaseline down first and several coats of all coat, or the all coat first and then the Vaseline, you usually don't have issues with things sticking. So to check your alignment, what we're going to ask you to do is to show this to a faculty member before you begin to mix your orthoacrylic to fill in your edentulous area. And so you would then invert the surgical round burr and make sure that that alignment lines up with where you marked your X. So if your X is kind of swervy, then that it should at least line up. Now, notice that the burr is able to stand without finger pressure, so we're not trying to create a hole, a huge hole where the burr is flipping around, okay? So it's just enough so that that is at least maintained within the surgical guide material. Okay. So the ratio for your orthoacrylic, and you need to make sure that you know this, would be 2 to 1. But we are going to provide you with the materials already pre-measured, so you do not have to worry about that. So you'll get a little vial of liquid and a little cup of powder, and you will have a paper cup to mix it. Ideally, what you should plan on doing is perhaps work in pairs or a group of 3, and you could just mix up enough for the 3 of you, and you could probably syringe in enough. Since we're only doing one site, that should be enough for all 2 or 3 students, okay? The other thing is, as many of you, well, some of you may know, this resin, the monomer, has a very unique smell. And I'm not certain about ventilation in the simulation clinic. We will all have a contact high and be dizzy. So it is, and we have no windows to even open up mine. So it is best for you to try and work in groups of 2 and move quickly, okay? Because it'll kind of like the glue smell, all of that fun stuff. Or nails the line, for those who know all about that, okay? I will provide you with a plastic syringe so that you can syringe the material in, and ultimately, this is what you're going to do. It is important that you not only check this alignment, but you're going to also make sure that you have either a straw, and I can provide straws because that seems to work a little bit easier, or if you're going to use your surgical round burr, you're going to Vaseline the shank of that burr so that it slides right out. If you don't do that, then it's going to stay, and then it's kind of a challenge trying to get that out. So that's going to stay in the incisal portion of your template material, and you're going to syringe material within so that it exudes out. You should see some express onto your cast. So it shouldn't be all on the tabletop or in the palette, but just a little bit, okay? You're going to wait for at least 20 minutes. It will get significantly warm, and then it will cool down. So usually after the exothermic reaction, you're ready to go. Okay? Next, at that point, you're going to gently try and remove this from your cast. It may be helpful for you to soak that in some water for about 10 to 15 minutes, and then typically that kind of pops right off. If you break off any adjacent teeth, don't freak out. We're just going to keep moving from that point, because that happens sometimes. Again, this is a working cast. What you're going to do is then take your lab cutter materials, not this burr. This would be the burr that you would utilize to remove the stone for your cast earlier on in order to create that center circle for vacuum purposes. I would use the other cross-cut burrs to trim, okay? This is too aggressive for you to trim just for one area, and I don't want someone to remove a nail bit. So ultimately, this is what you should end up with. And we are only going to do the central incisor, so please do not focus on the premolar area. What I want and need for you to most pay attention to is that once you trim this, that you pay attention to the fact that you have relieved the gingival embrasures here, and that this is convex, right? But that you can still see just a little bit of space. If I look from a facial view, you can see just a little bit of space from that ridge on your cast. Maybe this shows it a little bit better. That's important. That's important so that as the surgeon is actually performing their surgeries and doing their first pilot holes, that they can see the tip of their instrumentation, okay? So you might want to start off making sure that it's touching, but then we're probably going to ask you to relieve that so that you can see at least a millimeter of space, okay? Or even if you place the surgical round burr there, or even the inverted end, that you can see just a little bit of space of your long shank burr, all right? Please don't worry if you have voids within the material. It's just a matter of, it's a small space, there's only so much you can do with that. You want to make sure that the stent is easy to remove and place. If it's not, 9 times out of 10, the surgeon's not going to use it. Here at the School of Dental Medicine, you are required to present your case to Dr. Porto. He approves it. It gets assigned to a department, either oral surgery or perio. You take that guide to the surgery, and you are to be there during the surgery, and you are to see the surgeon utilize the guide you have fabricated, or a guide that you and Dr. Porto have agreed to be fabricated by some type of source. If the case is a little bit too complex that we don't believe that you could make it in a satisfactory manner, okay? But it is imperative that if you have a patient that is scheduled for implant surgery, this is not the time for you to go on vacation. You are required to be there. It is part of your educational requirement, okay? There are different ways of doing stents or guides, and I just want to make sure that you know that what I presented is a way to do it. There's more than one way to skin the cat, but the goal is for it to relay or communicate to the surgeon where you have designed your restoration and where you want the implant, not the other way around. The surgeon does not determine where the implant fixture goes based on bone, okay? The restoring dentist does, based on where the restoration needs to be designed. It's 2 different things. So there's more than one way to do this. You could just utilize, rather than a occlusal gingival guide, you could use just a lingual approach. And that's just something so that the surgeon at least has an idea of where the implant needs to go, but they are limited by their movement. There's only one way that they can do this. If you have too much play in a buccolingual or mesial or distal fashion, and they end up placing the implant in that manner, now we have a problem. Particularly if we have adjacent structures and dentition next to, you could perforate a tooth, right? You could perforate the buccal plate of bone. You could apply pressure to a nerve, which are all not good things, right? So that's why it's important for you to plan out where you want your implant placed. Ultimately, if you plan appropriately, this is what we're going to end up with, something that works out lovely, okay? Otherwise, it's not so lovely. And that's when it gets to be harrowing for most. Okay? I think that is, so I'm not going to go into all of that because some of that has changed, but that's the gist of that. So, what I'd like for you to do, I need for everyone to at least go down to the simulation clinic. We're going to divide up. It looks like it's 5 of us. Yes, 5 of us here today. I'm going to distribute components to you. Please make sure you do not lose these, okay? And then if you are working towards other projects and you'd like to see us, we will be around to check that information. Yes?
Do you write numbers on these components?
No. It's gonna, so all of the components come packaged in something. What I would suggest you do is hold on to it and either put it in a, if you have a Ziploc bag, something, and put it all in the same place. Okay, for now. Yes, ma'am. No. Yes.
Are we gonna get project sheets for like the provisionals
Yes,
and the other
you will.
preps?
All good questions. Straight there.